My name's Stephen Paul. I'm with the Learning Development Managers, and I'm mainly involved with the Prevention and Management of Violence and Aggressions team based within CPFT. What I'm going to briefly talk about now is how the physical intervention programme has changed over the last 2 years. So 2 years ago, a physical intervention programme consisted of 4 days, where the first half day was basically just around conflict resolution. And the next 3.5 days would be on how to take a distressed and agitated individual to the floor, now the prone position face down or the supine position face up. A large part of those days was work around putting that individual into the prone position, because that was the most frequently used position within the trust at the time. All those techniques, they used flexion of the wrist, which when you're dealing with a distressed and agitated individual could cause a lot of pain, if it be that intentional or unintentional. So even before that, before the positive impactive care guidance came out, we started to look at changing our training package. Then when the package did come out, the positive impactive care guidance did come out, that kind of sped things up, made us review our training package a lot more, and it started off a lot of changes as well. So the first one we did is improve the number of the conflict resolution we did. We looked a lot more of de-escalation and communication. And we used such models such as the safe words to work with that. There's also a clear focus, it's always going to be on the least restrictive option. And sometimes the least restrictive option will be a hands-on approach. So what we did is we added some new techniques with different degrees of restriction, a more staged approach. So this was aimed at ensuring the least restrictive option is always used, and encourage communication and de-escalation at every stage, and can be stopped at every stage as well. These new techniques include the removal of all intentional prone restraint, and all the techniques we teach are either in the supine position, the kneeling position, sitting or standing. If the individual does take themselves to the prone position or unintentionally do go to the prone position, then they're turned over straight away back into the supine position. Remove the use of flexion, because either intentionally or not, that can cause pain and can be deemed as a pain compliance technique. And within the programme, we also run talks on the Mental Health Act, the Mental Capacity Act, and look at the legalities around restraint. We're also running talks on clinical risk to try and get people thinking about triggers and causes. This also assists with intervening in situations early to try and prevent it escalating to the point where we have to go hands-on. Whilst we know that each of these changes will not take away the risk of an injury happening, because if restraint is still happening. So what we've done, and I've added the 5th day onto the course, which is a MERC course, a Medical Emergency Response course, which is an ILS equivalent. And this looks at the observations, physical observations of an individual while they're being restrained as well. So our next steps now is to re-review our training package. The way we're doing that now is by going onto the wards, spending time with the staff, with the patients, and look at the challenges they are facing at this point. And the next stage after that, well, the stage constantly after that, is to get in some more peer reviews and get some more expert buying and peer input, because that's how we want to have our courses. That's what led. So that's our future practice to be led by expert by experience. Thank you.
Thank you. Thank you very much, Stephen.